Welcome, everybody. Welcome to the Arrhythmia Academy and to this episode of the Journal Club. My name is David Duncker. I'm an electrophysiologist from Hannover, Germany. And today we will talk about leadless pacemakers in patients with chronic kidney disease. And it's a great pleasure to discuss this topic today with Dr. Gianfranco Mitacchione. He's a cardiologist and electrophysiologist from Brescia, Italy. And he will give us a short presentation and then we will have a brief discussion around the topic. So Gianfranco, thanks for presenting.
Thank you very much, Dr. Duncker, for the introduction. And thank you for giving me an opportunity to present my research and our findings on this platform. Current guidelines recommend leadless pacemaker over transvenous device in high-risk patients as those on hemodialysis, even if the choice of a leadless pacemaker in this subset of patients is driven mainly by MICRA approval and post-approval studies with limited follow-up data. It is well known that patients on hemodialysis are extremely vulnerable to infection, and the risk of infection is further increased by the presence of transvenous pacemaker. In addition, in those patients, it is important to maintain venous system pattern for the need of dialysis fistula, further limiting the use of transvenous device. But apart from hemodialysis patients, historical data show that pacemaker-related complication and infection risk are high also in CKD patients not yet on hemodialysis. Another issue that needs to be considered in this context is the incidence of CKD progression. In this projection, the progression through hemodialysis among CKD patients is expected to grow up 24% within 2026. And obviously, CKD worsening will be associated to the increasing of the risk of pacemaker-related adverse events, such as infection. Therefore, a patient implanted today with a transvenous device in CKD stage G4 may need hemodialysis treatment soon after. In addition, even through CKD progression may lead to kidney failure and renal death. These patients are more likely to die from cardiovascular complication before reaching end-stage kidney disease. For this reason, it's important to consider all CKD patients as a fragile group, not limiting this status to patients on end-stage kidney disease. In the light of the limits on CKD population, the aim of our study was to provide information on leadless pacemaker safety and efficacy at implantation and during subsequent follow-up in CKD patients according to different stages of CKD disease. Data of the study derived by the eLIPO registry, an international multi-center observational study including patients implanted with a MICRA VR or a MICRA AV in 15 centers in Europe and USA. In this retrospective analysis on 1,748 patients were included from June 2015 to October 2023 with a median follow-up time of 3 years. Patients were divided into 3 cohorts according to CKD stage and defining basing on CKD EPI score as recommended by the current guidelines on chronic kidney disease. So we identified 3 groups: patients with normal kidney function, patients with CKD stage G3A, G3B, and patients with CKD stage G4, G5. Our primary outcome was the comparison of major adverse events across the 3 cohorts. In this case, major adverse events were identified with the same criteria of the investigational device exemption study of MICRA device. Secondary outcomes of interest were all-cause mortality and leadless pacemaker performance. After stratification of the study cohort, overall CKD patients resulted in 42%, with only 9.4% of them belonging to CKD stage G4, G5 group. In this latter group, the majority, about 75%, were on hemodialysis. As attended, cardiovascular comorbidities were directly proportionate to worsening of CKD stage. Here we can see a table that showed the implantation feature and some outcomes. You can see that longer procedure and fluoroscopy time were in CKD patients. Interestingly, the proximal septum was preferred implantation site in advanced stage of CKD, while major complication rates were comparable between groups, and a higher all-cause mortality was in CKD patients. Just look the indication for a leadless pacemaker. Patients with normal kidney function, CKD stage, were more likely to be implanted with a leadless pacemaker because of atrial fibrillation with slow ventricular rate or intermittent complete AV block than those with CKD stage G4, G5. Conversely, sinus rhythm with intermittent complete AV block was the main reason for a leadless pacemaker implantation in patients with advanced stage of CKD when compared with patients with normal kidney function, as well in those with the stage G3A, B. This translates to an extensive use of micro-AV in advanced CKD stage. This is a strange result in the light of the strong association of CKD and atrial fibrillation, which is proportional to the decrease of renal function. One possible explanation is that those patients with lower life expectancy due to advanced renal and concomitant cardiovascular comorbidities such as atrial fibrillation are less likely to be offered an invasive procedure, or probably they died before the need of a pacemaker therapy. In our court, the choice of a leadless pacemaker over a transvenous device was primarily due to a perceived high risk of infection in patients with CKD. This choice was particularly crucial for patients with advanced CKD stage because of the concomitant or potential need of hemodialysis treatment. In fact, as attended, vascular concern was more represented in advanced stage of CKD, this in order to preserve central venous access for the creation of a dialysis fistula. Let's go over. We can see our primary outcome of study. Just a look. When patients, the cumulative incidence of major adverse events was comparable between the three groups. Also, after adjusting for confounders. And these were a great result about the safety of this device. After adjustment, also for confounders instead, the all-cause mortality rate was significantly higher in CKD stage G4 and G5 than in the normal kidney function group. So patients with CKD stage G4, G5 had a more than 1 times higher risk of mortality than patients with normal kidney function. Let's see what our finding about electrical performance. Despite within normal range, the pacing threshold was slightly higher from implantation to 30-day follow-up period, with no difference observed during the subsequent follow-up. This in the group of CKD G4, G5, as well in G3A, G3B. This higher pacing threshold may be attributed to several factors affecting the leadless pacemaker implantation. First of all, a lower pressure applied during leadless pacemaker delivery in this such perceived fragile group of patients could drive these results. Also, there was a higher prevalence of patients who had previously undergone a transvenous lead extraction, and we know that the leadless pacemaker positioning in the same site from where a transvenous lead is extracted can affect the pacing threshold. This is because of the presence of scar tissue, or a light clot overlap between a leadless pacemaker and the endocardial surface because a longer procedure time that was found in patients with CKD. But this is a slide that represents the rate of patients showing a high pacing threshold above 1 millivolt or above 2 millivolts in case of very high pacing threshold, we can see no difference regarding these parameters were found between groups. And the cumulative rates of pacing with high pacing threshold, about 8%, and very high pacing threshold, near 1%, were similar and consistent with historical data after 3 years of follow-up. In conclusion, in this real-world setting, despite the high prevalence of CKD in patients undergoing the leadless pacemaker implantation, those with end-stage kidney disease resulted underrepresented. Although the cause of mortality were higher in advanced CKD stage, thus identifying these as a fragile group of patients, the major complication and leadless pacemaker electrical performance were generally comparable across non-CKD and different CKD stage, including patients on hemodialysis. Due to CKD progression through end-stage kidney disease, a leadless pacemaker should be considered also in non-hemodialysis CKD patients, as these devices are safe and offer clinical benefit for this population, also considering the progression of the disease. Thank you very much, Duncker.
Yeah, thank you very much, Gianfranco. Excellent presentation. I think the last point of your conclusion should be pointed out. So you nicely showed that actually all CKD patients are a fragile group, not only because of infection risks, etc., but from a clinical point of view, you would recommend to not make it dependent from the CKD stage, but all CKD patients should be considered at least for leadless pacemakers. Is that right?
Yeah, I see that's right, because this disease is has a bad progression, even in the light of dapagliflozin therapy that probably improve the outcome of these patients. But we know that probably a pacemaker device will survive to patients. So I think that a lot of patients will go through hemodialysis or end stage, just bringing the risk of the device. So we have to think about it, particularly in the light of new leadless pacemaker device, probably able, not probably, but able to a dual chamber pacing.
And does the complication rate differ between the different groups? I mean, actually, your study didn't show that, but actually, we look at two different control groups, right? CKD versus non-CKD patients and leadless pacemaker patients versus transvenous pacemaker patients. Can you extend on the difference and on your patient choice? Which device for which patient?
Honestly, this registry was just on leadless pacemaker, so unfortunately, is out of the perspective of the study to make a comparison between transvenous device and leadless device in CKD or not. We can basing this result on historical data on transvenous device. There is a big amount of infection and cardiovascular and the complication in transvenous pacemaker. Also in CKD group, not on hemodialysis, infection is the primary worst outcome, but also pneumothorax and complication during transvenous device implantation. So we think just the thing that the complications were comparable to non-CKD group is, I think it is a good result.
And do you think there is any difference in follow-up of these patients after implantation compared to standard patients or non-CKD patients? Is there anything to think of?
Yeah, and as you can see, we lost a lot of patients in advanced CKD stage because they died during the follow-up. Okay, not for leadless device complication, but the follow-up of CKD patient, particularly on hemodialysis, could be easy because there are patients more prone to come in the hospital for kidney visit or dialysis or whatever. So I think that this could be a good choice for these patients.
Okay, fantastic. Thank you very much, Gianfranco, for this wonderful presentation and very nice discussion. And thanks everybody for joining us for this Journal Club. See you next time.